Good morning and welcome back everyone to MPHA's 2020 virtual conference. We're excited to have you here and are excited to be joined by Ann Connors and Alicia Rice from MaineGeneral's Peter Alphon Prevention and Healthy Living Center. This morning they'll be talking with us about COVID-19. A community health team adapts and innovates in response to the crisis to serve rural communities. A couple reminders before we begin. If you have any questions for Ann and Alicia about their presentation, you can enter them in using the Ask feature that's on your screen. And also, please don't forget to complete the evaluation that you can find by clicking on the feedback on the session page. But with those quick updates over, I'd like to introduce Ann Connors, who is the Manager of Community Programs in the Population Health Department at MaineGeneral Medical Center, and Alicia Rice, who is the Grant Program Manager with the Prevention and Healthy Living Center at MaineGeneral Medical Center as well. So thanks to you both for being here. We're looking forward to your presentation this morning.
Thanks so much, Heather, and thank you everyone who's joining us virtually. We'd love to be seeing you in person, but we know this is the best way during the era of COVID. We have nothing to disclose with regard to commercial relationships. Just want to briefly review our learning objectives. By the end of this session, we hope that you'll be able to describe the components of a community-based workforce, that you can name some innovative and evidence-based responses to this pandemic crisis by a community-based workforce, and that you can describe 2 educational interventions for vulnerable populations. While we can't see you in person, and we do want to try a little bit to make this interactive, so we're going to venture into the poll question territory. So our first poll question is, how much have you heard about a community-based workforce? A lot, a little, or nothing? And we'll wait a minute as you respond to this poll. I think one silver lining of COVID has been that, there's been more attention in the literature to a community-based workforce than we might have had without COVID. So while we wouldn't wish COVID to have happened, we do see silver linings in some aspects of it.
And it looks like from the results, 64% know a little, 29% know nothing, and 7% know a lot.
Okay, so the people who know a lot, email me so we can have a learning community going on. And it's great that most people have some familiarity of a community-based workforce. So I just want to define some of the components and set the stage a little here. So during COVID, we've heard some calls for more rigorous funding of a community-based workforce. We've heard calls for the establishment of a community health service corps. Currently, we believe there's about 59,000 community health workers pro matoris in the country. And obviously that's just a fraction of what we need to meet the need, especially in the era of a pandemic. Homeland Security recently designated community health workers as essential critical infrastructure workers during the time of the pandemic. Some roles for community health workers in COVID have been contact tracing and linking people who may be quarantined to social and health supports, helping people address unemployment and mental health needs. Health Begins has developed a great guide, a community-based workforce strategy. If you're really interested in, kind of delving a little deeper than we'll be able to do in this half an hour. And a volunteer example that you may have heard about or you may have seen happening in your own communities are mutual aid networks where neighbors kind of band together in a more structured way to provide support, for example, to maybe elderly residents who can't get out or don't feel safe going to the grocery store. So delivering them groceries, helping them access medical care. Some other terms for community-based workforce members: health educators, peer specialists, recovery coaches. You see those two roles mostly in the mental health and substance use disorder arenas. As I mentioned before, volunteers can be community health workers. And mostly community health workers are situated within community-based organizations that tend to be nonprofits. We're going to be talking about our experience of a community-based workforce here at MaineGeneral. So obviously we're a healthcare system. We serve Central Maine, and we are a nonprofit organization. So this brings us to our next poll question. Does your organization employ community health workers and/or health educators? I'd also be interested in the chat function. If you do feel that you have components of a community-based workforce in your organization, are there other terms that you use for that component of your workforce? Navigator might be one, connector. The health reach practices in our areas have essentially the role of a community health worker, and they call them community connectors. So there's a variety of titles, and it's really more about the function of the work that, puts it under the umbrella of a community-based workforce.
Oh, votes are still trickling in, but we're about 60% at yes and 40% at no.
Okay, now that's really encouraging. That's great that there's such a percentage out there that are using this vital role, especially in these really difficult times.
So these are all the community-based workforce roles here at Maine General Medical Center. In this presentation, we're really focusing on the community health workers and health educators as that is within our department. While other roles like social workers, peer managers, peer navigators are, as Anne mentioned, within the organization, we collaborate and refer to each other.
So during this time of the pandemic in our state and nation, our community health workers and health educators who work in the same department but on different initiatives, typically have different kind of core competencies and different scopes of work that they're doing. But we really came together to address some healthcare screening needs and to reach out to both patients, community members, and community organizations to assess COVID-related social needs. And we'll be giving you some more concrete examples of that as we move through the presentation. So our next poll question is, did your organization redeploy staff during COVID? And one of the reasons we're asking this is we completely had to redeploy staff because a lot of our traditional points of intersection stopped during the pandemic. So for example, colonoscopy outreach for, colorectal cancer reduction, low-dose CT scans, all these elective processes stopped, as did all of our community outreach work, like group gatherings, going to a food pantry or a soup kitchen and meeting with people there, one-on-one sessions. All of that stopped in that initial 3-month period following the governor's emergency order when we were in lockdown. So we had to redeploy staff, and we'll be talking about that process and just wondering about your organization's experience.
And we'll again likely have some more votes come in, but it looks like we're settling around 67% said yes, they did have to redeploy staff, and 33% said no.
Okay, so yes, to the 67%, I feel you. It can be an anxiety inducing process to do this, but it can also be really positive because it shows that we're being nimble and really responding to the needs in our communities. So this is a couple of examples of how we redeployed staff. On the left, we're meeting Mark. He's a community health worker, and he was redeployed to a long-term care facility within our healthcare system where he was screening all staff and visitors coming into the facility for COVID to keep this most vulnerable population safe, because we know the high rates that were occurring in congregate care settings. And on the right is Jane, another community health worker on our team, and she was redeployed to our needle exchange, a harm reduction program. This picture is there, and she was also administering health screenings to community members coming in to access that service.
Great. In addition to the redeployment sites that Anne just mentioned, our in-person health education classes were also put on hold during COVID, and our staff were redeployed in various ways. So we will continue to talk about that this morning. Our teams work to develop the screening process to minimize risks for individuals that were entering these facilities. So these processes really allowed for our local YMCA, our children's center, to operate as an emergency child care center for hospital and other essential workers. And we did this in close partnership with our sports medicine clinic here at MaineGeneral. Also, the Alphon Youth and Community Center, one of our local partners, had begun putting in community gardens, and that intent was to serve and produce up over 1,000 meals daily to AYCC members and the community. Our local also AYCC was able to safely utilize volunteers and staff to provide these meals. And as you know, many of the children relied on school provided meals during this time. So with the schools being closed, the AYCC really stepped up and were able to distribute meals to these local families.
And just in case you're not aware, AYCC is the Alphon Youth and Community Center, and it is located in Waterville.
Thank you, Anne.
Oh, sure.
Also, outreach to community partners is another important aspect of the COVID-19 response efforts. Many of the organizations that we do partner with in the community, such as faith-based organizations, town offices, they had really been faced with challenges of continuing to provide their important services while being safe and practicing social distancing. So we really worked to assess the needs for, it could be masks, it could be safety protocols. We also put together some packets, resource packets that included harm reduction services, food, oral health, information for your health, cards as well. And these packets also included print resources from the CDC, such as, hand washing, prevention, symptoms to be aware of. And a win to share is our team really established new relationships for continued collaboration with our community partners, post-COVID. So great win. Also, in addition to helping our community partners, we did individualized outreach as well. So we really ramped up our telephonic wellness support during these times of social distancing, where patients really were feeling most isolated or more isolated. We worked with primary care to identify patients who would benefit from a COVID wellness check from a community health worker to link them with resources and ongoing support. In addition, the health education staff reached out to patients who had been referred to our department within the last 6 months for referrals such as a harm reduction referral to our evidence-based programs, any of our healthy living classes, as well as patients that we're seeing in the emergency department or express care that were in need of a primary care provider or a medical home. Also here, care management, the care management team and social workers were reaching out to patients who had received an emergency food bag within the last 6 months to see if there was any need for additional resources or additional food, help with food during the challenging times. So we really worked to develop this process. You can see in the chart on the screen. So clinical needs, social emotional needs, and then behavior change needs. Clinical needs identified: if patients were in need of a medication refill, we would provide a warm handoff to the primary care practice. Also, if there was questions regarding COVID, we may use 211 as a resource for the patients. For social and emotional needs, if there was food, transportation, housing, loneliness, emotional needs, we would connect them with what we have for programming, as well as our social workers and care management team in the practices. And then behavior change needs that include nutrition, mindfulness, stress reduction, tobacco cessation. We would provide the resources as well as opportunities for health coaching and ongoing telephonic support.
So this slide is kind of the inner workings of the clock, I guess. So how we redeployed our staff and how we defined these processes. We used workflows. Workflows, I don't expect you to be able to read this slide or see, what all the little boxes say, but for each new process we're talking about here, whether it was, new telephonic outreach or screening or distribution of food or educational efforts, we develop workflows. And the real benefit that this gives us is, the workflows made us clear about what's the problem we're trying to solve, what are we doing here, and whose role and responsibility is it to do what in this process. And I guess the final function to me is really iterative quality improvement, because you develop a workflow, you do it for 2 weeks, and then you see that you left out a step or something's redundant or something's not necessary. So our department really relies on these. And I guess the other thing I should add is that these are very useful communication tools with the practices. If there's a new process and information needs to be shared, the workflow can be shared. They can quickly look at it and grasp what's going on and what's touching their patients. So speaking of patient touches, this pie chart represents the total of our outreach from in a 3-month period, March to May 2020, and that initial shutdown of the pandemic. So our department reached more than 18,000 people during that period. One of our biggest efforts in terms of just sheer numbers was the distribution of dental goodie bags that we worked in partnership with Partnership for Children's Oral Health, and we distributed 8,000 kits. There was a real education need at this time because most dental practices were closed. People could not access care, and they were having a hard time understanding what was an emergency and what wasn't. So the dental wasn't. And the dental kits had some basic supplies, but also had an education card about caring for your mouth, your teeth, but also what's an emergency, what constitutes an emergency, and how you might access that care. The other big bucket of our work was the wellness checks, and that was calling patients of the practices and asking them, particularly vulnerable patients, if they were okay during this time. And that was, that's the 768 figure that you see there. Our food distribution, that's the 5,000? Yes. So our food distribution efforts were more than 5,000 people received meals. And then the blue is our health screening, the dark blue is our health screening efforts. I'm just checking to make sure I'm not colorblind. I'm realizing how close all these colors are. But that was our health screening. And then the smallest number at the 100 is our needle exchange screening, which our harm reduction program. So community members coming in for that. So I think, you know, this just speaks to the impact and the great benefit of the fact that, you know, with the core competencies of this community-based workforce, those skills are readily transferable to new work, right? I mean, a lot of roles, people can't pivot that quickly, but if you think of community health workers, you know, their ability to have empathy and to connect with people, their knowledge of community resources, you know, their skills at problem solving and connecting people, those apply, you know, pre-pandemic, during the pandemic, and post-pandemic. So if we think about establishing a community-based workforce more broadly in our country, I think that's one thing to keep in mind. I just wanted to share one of our success stories in that 18,000, you know, sea of work. So our hub is our central referral system here at Peter Alpine Prevention and Healthy Living Center. And we got a call during the pandemic from a woman who was in need of primary care and dental care. And she had a dental abscess and a pretty severe infection. So our health educator team got to work on linking her to a primary care practice. And our community health worker, who had specialized in oral health outreach and education, connected her to a dental practice. So far, so good. When she got to the dental practice, she needed penicillin to address the infection, and she didn't have the funds to pay for the penicillin. She had a Maine Care application in process, and since she wasn't yet a MaineGeneral practice, our patient of our MaineGeneral practice, our financial counselors couldn't help her. So the community health worker reached out to the Augusta town office for general assistance, and general assistance funded the cost of the penicillin. And in the course of kind of, you know, building this relationship, talking with this patient on all these multiple fronts, she talked about her substance use disorder and that she needed access to a Suboxone clinic. Well, the community health worker didn't have expertise in that, but we have health educators on our harm reduction team here at MaineGeneral. So she reached out to them so they could help connect her to a clinic where she could receive that care. So this was one phone call to this hub, and this woman was connected to all of these resources by a full team, you know, trying to meet her needs during the pandemic. And her other need, I forgot to mention, was social support, because she was isolated from her kind of support group. So the harm reduction team helped address that too.
That's great, thank you, Anne. So with the limits, so what we're doing now, so with the limits on in-person programming, we've developed a protocol for in-person classes. So that protocol is small group classes with no more than 10 participants, sanitizing high-touch areas, doorknobs, tables, chairs, yoga mats, before and after class, screening each participant that comes to our class at the main entrance. So temperature screening questions. We arrange the room 6 feet apart. So there's social distancing, of course, masking required, and then we do not exchange or provide any handouts. Those are all emailed or mailed out after class. And also for those that are not able to return to in-person programming due to their comfort level or high risk, we are providing one-on-one health coaching as well as telephonic group classes to help stay connected with this vulnerable population. And then also we've always wanted to have a video library of topics that include our content areas of healthy cooking and eating, physical movement, mind-body techniques. We now have that opportunity, and we're reaching the community in different ways.
So part two of what we're doing now is we are expanding our community health worker program to 7 community health workers. 6 will be focused on adult chronic disease and 1 on pediatric family work. In doing this, we're adopting the IMPACT model, which is individualized management of patient-centered targets. This is a model that the University of Pennsylvania Center for Community Health Workers has designed and has a strong evidence base around it in terms of increasing access to care, reducing costs, and improving chronic disease conditions. So we are right in the process of that work with UPenn, and we're all being trained in the IMPACT model, kind of soup to nuts, director level to the community health workers. We will be assigning community health workers both to a primary care practice and to a community partner site. We really felt it was important to serve community members who may not be patients of MaineGeneral, as well as obviously prioritizing, and caring very much about MaineGeneral patients, but we didn't want others in the community to be excluded from the program. So community health workers will have kind of a dual assignment and will accept referrals from community partner sites. Some of the challenges and opportunities, I'm sure everybody on this conference virtual session are, well aware of these, but, COVID has kind of laid bare some of the health disparities that exist in our society. And one of the greatest ones is the racial disparity. So people of color have been really disproportionately impacted by COVID. In Maine, for example, African Americans are about 2% of our population, and they're roughly 18 to 20% of our COVID cases. Another phenomena that we're seeing is, people delaying needed care because they are afraid to go out of their homes, they're afraid to go into the hospital or to their doctor's office. Putting off needed preventative cancer screenings. Vaccinations for children are way behind because of that initial shutdown. And then, of course, we have flu and COVID kind of aligning this year, whereas last year, COVID arrived pretty much after flu season had wrapped up. This year, that won't be the case. And the development of a COVID vaccine and issues around, equitable distribution of that vaccine and education and outreach about that vaccine. So in all of these areas, I hope that, the information we shared has provided more evidence about the benefit of how a community-based workforce could educate and empower people in these 3 really somewhat challenging areas. So I'd love to we'd both love to answer any questions you may have, and our contact information is here if you'd like to follow up with any questions or information.
Thank you, Anne and Alicia. It's great to hear the work you're doing with community health workers. I think, you guys are one of the leaders in that realm, and so to see them deployed and used during COVID is really helpful. I think we have time for one question. Could you talk a little bit about how you might apply some of these lessons learned maybe to the flu season as it's coming up, and how will you try to get people flu vaccines, safely and quickly?
Yes, I think, one thing we didn't include in our presentation, but is part of our community-based workforce, is every fall we offer school-located flu vaccination clinics. And we usually vaccinate between 2,000 and 3,000 children and adults. And we're this year adding some community clinics because of the need. And the model that we had to implement because of COVID, around the distancing and the precautions and all of that, we will carry that model into the COVID vaccination process. And so that's one key role. And I think the other key role is, the education piece. There's just going to be a lot of anxiety, fear, misinformation out there. So how do we reach the populations that really need the information, and how do we frame it in a way that they can understand? I think that's going to be a challenge, but also something particularly like the health educators, really have the skills to address.
Thank you. We appreciate it. And we'd love to chat with you both all morning, but we do need to move on to our next session. So I want to thank you both so much for being here and presenting, and remind all the attendees to take the evaluation by clicking the feedback button on the session page. And we will be back in just a few minutes with a presentation on job crafting. So we'll see you shortly.
Thank you. Bye.
Thank you.